Okay, good morning, everybody. Happy Saturday. Thank you all for taking time out of this beautiful Saturday here to join us to learn a little bit more about taking care of our backs and making sure that they aren't hindering us from being able to get out and enjoy this beautiful weather that we have. We're starting the good weather stretch in Maine, and we all want to take advantage of that, right? So this is a good time of year to be talking about some of this stuff and learning how we can effectively take care of it without the need for surgery and medications and all this good stuff. If we can avoid those things, we definitely want to help you do that. My name is Dr. Phil Finemore. I'm a physical therapist, and I own WorkFitME Mobile Physical Therapy, where I help busy Maine professionals to maximize their physical performance so they can live a happy, healthy, and wealthy life doing what they love with who they love. I'm very pleased to be joined by these two providers from Coastal Maine Direct Care, based out of Falmouth. Steve, Dr. Barr, good morning. Thank you very much for joining me, and please introduce yourselves and tell us a little bit about you and Coastal Maine Direct Care.
Sure. I'll start. Hi, everyone. I'm Dr. Alexandra Barr. My background is in family medicine and also board certified in geriatrics. I am one of the providers of Coastal Maine Direct Care, and I personally provide services and see people, older adults, ages mainly 65 and older. I see people in our office. I also do a lot of home visits and go to assisted living facilities as well as long-term care facilities. And my partner is Dr. Karen Saylor. She was unable to join us today, but she's also a geriatrician. It's a practice that we started about a year and a half ago. And because we wanted to spend more time with our patients and just provide better services for our patients. And then I'll let Steve introduce himself, but he has joined us and sees some of our younger adults. So take it away, Steve.
Yeah, my name is Steve Saylor. I'm a physician assistant providing primary care, direct primary care services at Coastal Maine Direct Care, and accepting patients 18 to pre-Medicare. And I'm here to talk to you guys about back pain today.
Awesome. That's fantastic. Again, thank you all for joining us, and we're gonna jump right into it here and start talking a little bit about back pain in general and some ways that we can manage it. So Steve, you can take it away and kick us off.
Okay, I'm gonna get my presentation going here. So if you're listening to this and alive, you've probably had back pain at some point in your life. 84% of US adults experience back pain at some point. And usually what we like to do is to break down back pain into several broad categories. For me, I like to break it down into scary back pain and non-scary back pain. But usually we also break it down in a time frame. How long has the back pain been there? Acute back pain is defined as less than 4 weeks. Subacute, 4 to 12 weeks. Chronic back pain is anything that's been lasting greater than 12 weeks. Some risk factors we have for back pain include smoking, obesity, age, female gender, physically strenuous work, sedentary work, psychologically strenuous work, low educational attainment, workers' compensation insurance claims, job dissatisfaction, and psychological factors such as somatization disorder, anxiety, and depression. The last of which, depression, really is a bigger cause of back pain than most providers really recognize. And broadly, we break down back pain into the type of back pain. So I consider scary back pain and non-scary back pain. It's kind of mechanical versus something else that's causing the back pain. So we break that down into mechanical low back pain, non-mechanical low back pain, and visceral disease such as in your organs, in your belly, or in your chest, where referred back pain can be coming from.
Steve, did you have some slides you wanted to share on your?
Oh, they're not being shared?
No.
No, if you go to the bottom and hit share screen.
Oh, I am sorry.
And then we can see your slides.
All right, let me get back out here. Oh, here we go. Share screen. Huh, I don't seem to be able to be sharing my screen. How's that?
Oh, perfect.
Good.
Oh, okay, there we go. All right, let's see. We go through. Okay, here we go. Sorry about that. So, but anyways, types of back pain, we'll break it down to mechanical low back pain, non-mechanical low back pain, and visceral disease, such as your organs and kidneys, belly, chest cavity. Mechanical low back pain, which is probably the more common form of back pain, includes lumbar strain, muscular and connective tissue, degenerative diseases, age-related osteoporosis or age-related osteoarthritis, or traumatic back pain, such as you might injure your back in a car accident. Spondylolysis, which is a type of back pain from a small back fracture, can lead to spondylolisthesis, which is like a slippage of the vertebrae on top of one another. And then we also have spondylosis, which is a big word for osteoarthritis of the back. It can be either osteoarthritis or it could be autoimmune, such as spondylitic arthritis. Disc herniations, spinal stenosis, and vertebral compression fractures are all examples of mechanical low back pain. A lot of times you'll hear healthcare providers talking about back pain with some of these words you see at the top of your screen. Spondylosis over here, or spondylolysis, is a back fracture. It's a fracture of the posterior pedicles of the lumbar spine. These are the kind of the stabilization points of the spine. You see these in rowers and athletes frequently. If that actually ends up breaking all the way through, you end up with what this is called here, spondylolisthesis. This is where one vertebrae of the back slides back and forth on top of the other, causing spinal stenosis through here, which is where the spinal cord runs. You have spondylitis, which is literally spine inflammation. This is tends to be an autoimmune disorder. And then you also have spondylosis, which is more of like a osteoarthritic type of back pain, usually a bit more focal than your autoimmune spondylitis. So a lot of spondies here. Non-mechanical causes of low back pain, which is what I consider this, scary part, concerns of back pain, include your neoplasias such as lymphoma, carcinomas, myelomas, tumors, infection, osteomyelitis, inflammation of the disc, spinal abscess, inflammatory arthritis, such as we mentioned before, ankylosing spondylitis, which is an autoimmune inflammatory cause of back pain. Showerman's disease, more of a disease of adolescence. It's when the forming of the spine causes a kind of a curvature of the spine. And then you have Paget's disease, which is a metabolic bone disorder. All these are examples of a non-mechanical form of low back pain that need to be taken into consideration. Visceral diseases include pelvic organs, such as the prostate, uterus, pelvic inflammatory disease, kidney diseases, abscesses, infections, stones. If anybody's had a kidney stone, this is not a mechanical form of low back pain, because no matter what you do with a kidney stone, you're going to be, you just cannot get into a comfortable position, but it causes back pain. Aortic aneurysms are causes of low back pain that are considered non-mechanical. GI disease, pancreatitis, gallbladder, ulcerative diseases all can cause low back pain, including lumbar fat herniation. An evaluation of low back pain in the office, the first things to start off with are going to be history. Where's the back pain coming from, its location, duration, severity. Constitutional issues to take into consideration are going to be fever, or weight loss, night sweats, neurologic symptoms, history of IV drug use or medications. Consider psychological or social factors in patients' low back pain. Physical examination are going to include your inspection. What's their posture? Is a person limping? Are they leaning off to the side? Do they have scoliosis or kyphosis, which is kind of like this curve up here in the upper part of your back? Is there excessive curvature of the low lumbar part of the back? Do they have humpback? Do they have sway back? Palpation can give you some idea of where the pain might be coming from. You want to press over the bony prominences, press over the muscle tissue, soft tissue structures, see if you can elicit any pain. Neurologic examinations can include checking for reflexes, sensation, and specialized testing such as a straight leg test like we have here. You flex the person's hip, straighten their knee out, flex their foot a little bit. All that's trying to tug on the sciatic nerve and put a little traction on the spinal cord. If it's positive and causes radicular pain, then a lumbar disc herniation may want to be considered. Special tests often include a Waddell sign, which is kind of a joke in medicine because these are tests that you do to see if there's a non-organic form of the patient's back pain. One of my favorite signs is a patient who might be faking it is called pain on near palpation, when you're coming almost close to touching the patient's back and they're already wincing in pain before you actually even get there. Then you need to take in consideration, whether or not the pain's actually coming from the back or not. Some labs to consider in the early assessment of back pain are going to be some of your inflammatory protein biomarkers like C-reactive protein, SED rate, CBC. Those you're going to want to consider based on your history, whether or not the person's losing weight. Is there some other sign of a non-mechanical low back pain situation? Imaging, typically in the acute phase of low back pain, us as providers, we always tend to want to do something, but this is a good example of doing something might actually be harmful. There was a big study done with a VA center with almost 500,000 patients where they were randomized into getting an MRI with x-rays for their low back pain or not getting x-rays or MRI in the initial phase of the acute low back pain. And what they found was the more aggressive you are imaging early on in the phase of acute low back pain, the more likely it is you're going to experience higher costs, more likely to have surgery and poor outcomes. So you need to really consider the utility of getting imaging studies in the acute phase of low back pain. And American College of Physicians actually discourages the routine imaging studies of low back pain because it tends to lead to worse outcomes. Here's an algorithm. It didn't really come out very well here, but it's an algorithm that we can use when trying to assess whether or not we need further imaging studies in assessing a patient with low back pain. Starting to get into the treatments of non-specific low back pain. Again, break it down by category: acute, subacute, and chronic low back pain. Acute non-specific low back pain. Reviewing the literature, there's really not a lot of evidence in the literature of things that will remove the pain in your back or treatments that are real good in the acute phase. The most important thing with acute non-specific low back pain is you do not want to do bed rest. I remember back in the 80s, that was kind of common, limited immobility, laying in bed tended to be the treatment. Now we know that that's bad. If you do have acute non-specific low back pain, it's important to encourage people to get back to normal activity with modification. Most important thing is to avoid inactivity. Subacute low back pain, we start using some pharmacologic treatments versus non-pharmacologic treatments. Medications include non-steroidal anti-inflammatories such as ibuprofen, naproxen, Tylenol, muscle relaxers, and then non-pharmacologic treatment, which is preferred in this phase: superficial heat, spinal manipulation, which Dr. Barr is going to be talking about later, acupuncture or massage. And then in chronic low back pain, we have some moderate evidence that there's exercise, multidisciplinary rehabilitation, OMT, osteopathic manipulation, acupuncture, mindfulness-based stress reduction. And then there's some low quality evidence of chronic low back pain that Tai Chi, yoga, motor control, progressive relaxation, EMG feedback, low-level laser therapy, which I'm not even familiar with, and cognitive behavioral therapy can provide some limited help. The subacute back pain, in 4 to 6 weeks, you've made it through the acute phase, back pain still there, patient comes back, say, Steve, I'm still being bothered by this back pain, what can we do? You want to reassess, see if there's any signs or symptoms that might indicate a more nefarious process going on, such as infection. If there's persistent radiculopathy, such as pain going down the leg, spinal stenosis symptoms, at that point you can start really considering obtaining an MRI. However, you really want to consider whether or not the patient's game for getting anything done. If a person has a small disc herniation with radicular symptoms, but they don't want to have surgery, it really makes no sense in moving ahead with getting an MRI, which can cost thousands of dollars, and find other pathology in the back that's really completely unrelated to the back and would otherwise be considered benign, such as disc bulges or disc herniations that are asymptomatic. Reassess a cancer risk. Ask the patient about their cancer history, age, smoking history, family history, weight loss, anemia. Consider the inflammatory protein biomarkers, SED rate, CRPs, and consider getting images at this point. Osteoarthritis of the hips can also be a source of low back pain. And if there is no specific concerns identified in this 4 to 6 week subacute low back pain, we can continue with conservative treatment. Chronic back pain, which is lasting more than 12 weeks. Patient's been through the acute phase or subacute phase, back pain still going on. Still haven't been able to find any specific concerns of pathology. You know, at that point, you can start considering getting plain radiographs or consider referring the patient to a specialist for further evaluation if you haven't been able to make a diagnosis at that point. Considering treatments, pharmacologic versus non-pharmacologic. Obviously, we mostly like to do non-pharmacologic treatments, which include heat. There's moderate evidence that heat may reduce pain and disability for patients with less than 3 months of symptoms. And when I say moderate evidence, that's pretty good evidence. Usually, if you have moderate or limited evidence, that's usually pretty decent evidence that the treatment's going to provide some benefit. There is something about heat on your back that does make it feel better. Spinal manipulation, there's moderate evidence to support its use. Cracking the back, there's always something that does make the back feel better when you crack it. Massage, massage hasn't really shown to have a lot of great evidence of reducing back pain. However, unless it's being chosen by the patient. So always need to take into consideration the patient's needs and desires for really treating their back pain, as long as it's not harmful. Acupuncture, there's some limited evidence that there's benefit. However, it's inconsistent. It's a little hard to do trials with acupuncture. It's hard to have a sham acupuncture trial. However, it's not shown to be harmful and tends to be more helpful in chronic back pain patients. Exercise and PT, there's limited but good evidence that it's helpful in low back pain, but better evidence for subacute and chronic low back pain. Treatment, there's little to no evidence to support the use of cold treatment for the lumbar spine, muscle energy technique, traction, lumbar supports, mattresses. Changing mattresses does not necessarily help improve low back pain. Yoga does not seem to be that helpful in acute low back pain, but it does seem to be helpful in patients with chronic low back pain. Paraspinal or trigger point injections for non-specific acute low back pain. We've all tried them before as providers for the most part, and almost never does it actually end up working. Pharmacologic therapy that we use, non-steroidal anti-inflammatories. These include your ibuprofens, naproxens. A lot of people use these. They say they don't work, but are taken inconsistently. In my opinion, and most evidence indicates that if you're going to start on a non-steroidal anti-inflammatory, if you don't have any trouble with taking one, you need to take the standard dose for a minimum of 2 weeks before you can say it's not effective. It takes about 2 weeks for your body for the non-steroidal anti-inflammatory to kind of suppress those prostaglandins or those inflammatory proteins that are causing pain. There's moderate evidence that it works better than placebo. However, you also have to evaluate the stomach risk, kidney toxicity risk with taking these medications. And I typically try not to prescribe them for more than a couple of months at a time. Tylenol, there's pretty high quality evidence that Tylenol is really not helpful in acute low back pain unless it's combined with a muscle relaxer. Second line therapy for treatment of mechanical non-specific low back pain include muscle relaxers. We have the benzodiazepine class, which include Valium and lorazepam versus the non-benzodiazepine. All of these tend to cause sedation. But there's pretty high quality evidence that non-benzodiazepine muscle relaxers are more effective than placebo, particularly when they're combined with an anti-inflammatory or Tylenol. Benzodiazepines are very effective muscle relaxers, but there's limited evidence and there's a high risk of adverse effects such as sedation and possibility of abuse. Opiate pain medication, back in the 90s and early 2000s, opiate-based pain medication really took off heavily. It was became quite a problem, still quite a problem in the United States. Currently, the CDC recommends very limited use of opiate-based pain medication like the Percocets or painkillers, morphine and whatnot, to limit that use to less than 3 days and no more than 7 for most patients. Most of the studies are focused on chronic back pain as opposed to acute low back pain. It's really high risk to start treating patients with opiate-based pain medication in a non-specific low back pain situation. First of all, it's, the medication doesn't last very long. If you take it, it's only going to last for a couple of hours. It is effective at making people feel better. However, its continued use can lead to dependence and diversion. And now you have 2 problems. And so I tend to avoid prescribing these medications for patients simply because, I'm sorry. So I try to avoid prescribing those medications simply because once you get started doing that, then you have 2 problems. You have a person who might be dependent on opiates and they still have back pain. Tramadol is a different class of, it's in the opiate category, might be somewhat effective. Again, I try to avoid using these. And there's limited to no evidence for a role of oral steroids, capsaicin, lidocaine, herbals, antidepressants. These things had more of a role really in more of a chronic low back pain type of situation. In summary, most patients have non-specific acute low back pain at some point in their life. Over 90% improve with conservative therapy alone, including nonsteroidal anti-inflammatories, Tylenol, active rest, home-based exercises. Less than 1% have any serious type of etiology. History and physical are sufficient for evaluation of low back pain. That's less than 4 weeks. Identifying risk factors is important. Making sure there's no sign of cancer, signs of infection. Imaging at this point typically is not helpful, tends to be harmful. In subacute back pain, once we've made it through the acute phase and the back pain still there, we need to consider other causes other than mechanical. Obtain your SED rate, inflammatory proteins, consider to obtain x-rays, possibly MRIs if there's any concerning signs or symptoms. No concerning signs or symptoms, consider continued conservative therapy for another few weeks of PT. And chronic 12 weeks low back pain, need to really start considering further imaging such as an MRI or moving on to referral to a spine specialist to really get to the bottom of that. Let's see. So that is the end of my section there.
One thing I would, yeah, there should be, if you hover up near the top, there should be a way to say stop share. It should pop down and
stop share, pause share.
It should say stop. There should be a little red button that says stop.
Oh, stop share. There we go.
There we go. One thing I just wanted to say real quick before we jump into Alex's is going back to that exam that Steve was talking about. If you are in front of a provider with back pain and they aren't taking you through that, they're just asking you a couple of questions here or there and maybe watching you move a little bit, but just sort of asking some questions while their head's in a computer, you're not getting the exam that you should be getting. So those types of things that Steve went through are things that Steve, Dr. Barr, and myself take everyone through in a very comprehensive way, because it's very important to determine the root cause of the problem, because not all back pain is the same and should be treated exactly the same, especially from a movement and PT standpoint. I'll get into that a little bit in my part of the presentation, but I thought it was just a real important point to point out that if if you are in front of a provider, whether it's a physician of some sort, a physical therapist, chiropractor, whoever it is you're seeking out care from first, because you can choose who you go to first in the state of Maine, which is a great plus. But if they're not taking you through something like that to help you figure out what the best course of action for your problem is, find someone that will, because you got to
back pain evaluation is a participation evaluation. You definitely, as a hands-on active evaluation. Yes.
100%. Yeah. I just thought that was a real important point to make.
Yep. So Dr. Barr is going to talk about osteopathic manipulation. I'm going to make you the host. Okay, Alex?
Great.
Dr. Barr, there you go.
Oh, great. All right. Let me share my screen. Okay. Great. Can you see the PowerPoint?
Yes.
Great. Okay. So yeah, I concur with both what Steve and Phil said. If a thorough history and a thorough exam is what you need from whoever you're seeing. So if you're seeing a provider for any sort of pain and they're not putting their hands on you to examine you or evaluate you, you might want to find someone else. That's really important. So that was really thorough and really important. So first, before I want to talk about OMT or osteopathic manipulation, I get a lot of questions about what is the difference between an MD and a DO. I am a DO, meaning I went to an osteopathic medical school. It's a 4-year medical school, just like the allopathic or MD schools. We have the same coursework, your basic medicine, surgery, anatomy, all that stuff is the same, gynecology, psychiatry, and we can go into any specialty at the end of our residencies. But additionally, we do have extra coursework in what we call like how to diagnose somatic dysfunction and how to perform osteopathic manipulation. So we have additional hours in this, which is really, I think, important and really special. So part of the osteopathic philosophy is that structure and function are very closely related, and the body is a unit that if you left the body alone, it would naturally heal itself. But sometimes because of pain or because of different diagnoses or whatever is going on with the body is just unable to heal itself on its own, and it needs a little bit of help. So we first, after the thorough history taking and thorough structural exam, when I look at someone, no matter what they come to see, no matter what their complaint is, if their complaint is headaches, if it's back pain, if it's, COPD, diabetes, and I do my structural exam, I'm looking at your entire body and whatever might be going on that's interfering with the body's natural ability to heal itself. So I'm looking at asymmetry, I'm looking at tissue texture changes, if there's like redness or one part of the body versus the other, anything that's out of alignment. And so I look at the entire body all the way from top of your head to the bottom of your toes. And so it's a really thorough structural physical exam. And just taking into consideration the interconnectedness of our lymphatic system, our blood, how the blood is moving in our body, how our muscles and our bones, how all of that is connected. It's a very in-depth training process that we go through, and how to be able to look at someone's body, see what's out of alignment, and then perform different techniques and different treatments to realign the body to help people optimize their function, improve their pain, and just live, healthier, better life. So kind of back to what Steve was saying, does manipulation work? There are a lot of studies out there with OMT, and they're randomized trials of manual therapy. And this is just one example, since we're talking about back pain today. And it's from a spine journal from 2000. And it's looking at intense manipulation. And that means usually we're looking at 3 or 4 parts of the body that we're doing these techniques on. So this particular one looked at the upper back, the lower back, and then part of our sacral joints as well. And so it showed that, yes, doing OMT gets you faster initial recovery after your first visit. So typically patients are leaving with better range of motion, better ability to function, and less pain. And then this study showed a faster functional recovery overall. So after a week, people are really feeling better and getting back to a better quality. So what are these techniques? And I don't want to go into too great of a detail, but it's not just, cracking a back, it's muscle energy, how if I'm moving someone's shoulder or neck and I hit resistance, there are different techniques that I know that can kind of let those muscles relax, let the myofascial and the joints and the ligaments relax. So muscle energy, counter strain, that has to do with trigger points. So if I'm feeling for muscle spasm, there are different techniques I can use to kind of help that spasm go away. Myofascial release, lymphatic drainage. And then it's the HBLA, that's what we typically refer to as cracking someone's back. I don't do a lot of that because my patients are mostly older. And so if you have brittle bones or osteoporosis or osteopenia, you don't really want to be cracking backs. But for a younger, healthier adult patient, that's perfectly fine. And I also wanted to show these pictures. I think it's really important. We're talking about back pain today, but back pain can be from a lot of different causes. So neck pain, headaches, different leg lengths, hip pain, shoulder pain. So it really is, you're not just zeroing on a narrow topic. It really is the whole person, the whole body. Different types of the body can be out of alignment. And so that's what's great about OMT, is that you can pick up on things, treat different areas, and then really give people greater function and greater mobility and less pain, because you're looking at the whole body and treating the whole body. So why OMT? It's very comprehensive, as we've been saying, thorough history, thorough structured exam, and then these different techniques. It's very safe, so you can use it alone, without pharmacology or any other treatments, but with the addition of, NSAIDs, heat, things like what Steve was saying, it really is a great way to treat pain, and with a lot of different other techniques. It's very gentle, relaxing, and also highly effective. So my patients come to me, and my goal is that they leave my office with better range of motion and less pain. So that's always my goal. And OMT is great too. We're talking about back pain today, but it can be used for so many different things: fibromyalgia, insomnia, TMJ, headaches, arm pain, hip pain. So if you have questions and you're curious about OMT, or you have friends who want to try OMT, there's my phone number there and my email. happy to answer any questions, or if you want to book a session with me, happy to do that as well. So thanks so much.
Awesome. We did have a question, Dr. Barr, pop up in the chat asking
Oh,
about
okay.
asking about the difference between OMT and chiropractic.
So great question. Chiropractors, number one, do not go to medical school. So I'm a little biased that, DOs, we do go through intense, medical school residency. So I did a residency in family medicine and also a fellowship in geriatrics. So I have like a medical degree, which I think is important that you have that base of, thorough anatomy, physiology, systems, body and organ systems underneath my belt, on top of the addition of OMT. And I mean, I guess I usually tell people that OMT is kind of a mixture of massage and chiropractic. Like when patients come to see me, I'm not there just to crack someone's back or crack someone's, whatever joints. Like I'm looking, in my opinion, I think it's more thorough, much deeper assessment. I'm looking at lifestyle, I'm looking at diet, I'm looking at behaviors. So there's like an emotional, spiritual, medical component to it that I think is just a little bit deeper and a little bit more thorough than going to see a chiropractor. But I know people do go to chiropractors and they help them and they get a lot of benefit from them, but I'm a little bit biased. So yeah, any other questions?
I think that's a great synopsis, Dr. Barr. Is there's a I'm a little bit, and not to say not all chiropractors are only focused on that one thing, but that holistic approach from a very medical background is very important, I think. And in my personal experience, DOs who do OMT with their patients tend to be very quick to get other specialty areas involved that are going to help that person along, not just relying on the OMT alone to do the job, so that it can be taken to the next level. I know that's a conversation you and I have had. And I think that's important. I think that's an important difference as well.
Absolutely.
Yeah. Wonderful. So another great question here. How do DO work with physical therapists? That's perfect, because that's how I was going to segue into my part
segue, right?
of the
If
conversation.
I'm seeing someone in my office and, I feel like they need a little bit more, I don't know, work with a physical therapist, I usually, refer them to Phil. So I'll let you. I unfortunately have another obligation at 10. So I'll let Phil take it away. But if anyone has any other questions, I'm happy to follow up.
Awesome. Thank you very much, Dr. Barr. I really appreciate it. So yeah, I think the big overlap here, or how a DO and physical therapy would work together, is that the manipulation part of things can be very effective at getting things moving a little bit better, helping things just feel a little bit better. And then a lot of the hands-on techniques that I'm able to do as a physical therapist can support that very well. And then we're also going to look at the muscle activation, stability, and working into the strength and endurance things as well. Okay. So when I look at back pain, really when I look at any joint pain or any pain in the body, I'm looking at trying to help the client find a balance between getting the right areas moving the way that they should be moving, getting the right areas of muscle activated and working better, working into stability, and then working that into strength and endurance in the right muscle groups as well, and finding a balance in and around that area, not just at that point, but above it and below it, for a very comprehensive approach to how we're treating pain in that area. So a lot of the techniques that an osteopath like Dr. Barr can use, can help get areas that aren't moving well moving and get things feeling a little bit better from a pain perspective. Some of the hands-on techniques that I use and am trained in can help support that a little bit. And then we can kind of keep things there and keep you moving that range of motion in the right direction, and just moving your body, moving that area of your body a little more effectively, which is going to prevent you from slipping back into the reason you went to see Dr. Barr for the OMT treatment in the first place, right? So it works very well together to keep you progressing and not just falling back into the same pattern, I guess would be a good way to put it, that got us to the point where the pain is in the first place. So that kind of leads perfectly into what I wanted to talk a little bit about today, referring back a little bit to what Steve talked about with us in the beginning, the different areas or the different stages of back pain. One thing I wanted to mention is, when in that acute phase, that initial pain phase, keeping things moving and everything that Steve was talking about was exactly right. I think what can be very helpful in that stage is having some guidance and support of how to modify some of that activity. And depending on the cause of the back pain, which having someone assess and figure out, is this more of a disc problem? Is this more of a problem that some areas of arthritis are irritating a nerve, or is it a muscle strain or spasm? Having someone even just examine you and find out what those things are that are going to help you best modify your activity and move a little bit more effectively can be very helpful. So unfortunately, a lot of the research doesn't always do a great job of being able to measure that because it's not necessarily something that is as easily measured in medical research. But just knowing, all right, based on what you're feeling and what I think is going on with you, do more of this, do less of this to keep yourself moving, and let's get a few of these things working, try these things for pain relief. And then once that acute phase of pain is over and we've worked through that, or maybe more in that subacute where things aren't as bad as they were, but they're hanging on, that's when we can start doing a little bit more of the progressive exercise. And again, finding that balance between getting the right areas moving, getting the right muscles working, and then progressing into not only getting rid of the pain that you have now, but preventing it from coming back by maximizing that strength and in endurance factor. Okay. So I think that was one of the big things that we've also talked about today to really hit home, is the difference between those causes of back pain. Okay. So I like to tell everybody that not all back pain is the same, because the true root cause of that back pain, whether it's coming from a disc pushing on a nerve, whether it's coming from the nerve in your back not having enough room because of arthritis, or that spondylolysis or spondylolisthesis that Steve was talking about, whatever that the structural problem is in that area, really needs to drive how we structure your treatment. Okay. So I want to share my screen real quick and just show you how some of those things can have an effect on certain areas of our spine. So if we look at this image right here, this is kind of a zoomed in image of the low back, the lowest two vertebrae of the low back. So between each vertebra, we have our discs. The spinal cord runs right down the middle, just like what Steve was talking about earlier. These out here are the nerve roots that come off the spinal cord and come out, and down in this area, they join together to create the sciatic nerve. I'm sure everyone on here has heard of the sciatic nerve and sciatica, which I'll touch on a little bit here as well. But another thing to keep in mind here is each vertebra has a joint on both sides of the spine, with the vertebra above it and below it. Okay, that's what these are here. So you can see there's not a huge opening here for these nerves to come out and do what they have to do. Okay. So if we have some arthritis built up in this joint, and that closes down that space a little bit, there's less room for that nerve to be doing what it needs to do and sending the signals it needs to send. If we have a disc herniation, which pokes out this way, that can fill that space and potentially hit on the nerve. Not always, but it can. And or if this vertebra is slipping one way or another, or we just lose height in this disc, right? So maybe it's not poking out, but all of us, as we age, we lose some water content in our body. Those discs shrink and shorten a little bit. Some of you may have heard of the term degenerative disc disease. I'm not a huge fan of that term because it's not a disease. It's not a disease if we all have it, right?
Right. It's like a normal part of aging that most people, right.
It is 100% a normal part of aging. So I hate that term. It's also why I hate imaging, because it mostly shows up because someone got an image of their spine, and it freaks them out, and it's unnecessary to say that. It's a normal part of aging.
Or bulging disc.
Right. Bulging disc, same thing. That happens. I've got another little image here I'm going to show people that I think is pretty powerful to hit that home. But when we're talking about any of those things I just mentioned that could cause some impingement or some irritation on these nerve roots, it's not just that the disc is shortening or the arthritis is there, because if we have some of that degeneration in the disc or that arthritis, there is actually no treatment that's just going to take that away, right? We can't make those discs higher. We can't get rid of your arthritis. But what we find is that particular area of your spine is having more stress placed on it because of imbalances we're seeing between mobility, muscle activation and stability, and strength and endurance in certain key muscle groups throughout our spine, throughout our core, throughout our hips, that cause a certain area of that spine to have a little more stress placed on it, which then causes irritation of that nerve. Okay. So again, something to further this point here. This here is one of my favorite studies. It's called the vomit study. Not that kind of vomit. It is the Victims of Medical Imaging Technology study. And if we zoom in on the lumbar,
right.
Yeah. If we zoom in on this is part of what Steve was talking about here. If we zoom in on the lumbar spine here, 40% of individuals under 30 present with disc degeneration. Okay. So it really doesn't matter whether you're 60 or under 30, you can have quote unquote degeneration in your discs. Bulging discs, you can see are quite common even in younger age groups. Most studies have found no link between degenerative changes on x-rays and MRIs and low back pain.
Right. That's why the recommendation really is, you need to be conservative with your imaging studies. Yeah. I mean, you tend to really want to jump right into imaging studies. People want a diagnosis. They want to know exactly what's causing that pain.
Yes.
But, it opens up a whole can of worms when you find something in there that probably doesn't even correlate to the pain.
Exactly. And if we're doing a good comprehensive physical exam, like that exam that we've already talked about, based on the movements that hurt and cause your symptoms, and what the patient is telling us is causing their symptoms, without an image, we're able to figure out, okay, I think this is more of a disc issue, which we need to treat this way. I think this is more of an issue where there's some stenosis, some arthritis buildup closing around that nerve. We need to treat this more this way. And in my exam, I'm even looking at certain areas of muscle activation, muscle strength, along with mobility through your mid and upper back, mobility and stability around your hips, the pelvis. And we're actually able to get very intricate and tease out what the true causes of the pain are beyond some of those structural things in the spine. Okay. And that's the real important part is, at the end of the day, and I've told patients this before, when they might have multiple things going on, maybe they have a little bit of a disc bulge going on, but they're at that age where they've probably got some stenosis or arthritic buildup too around that nerve. Unless the certain treatment techniques I'm doing are gonna make that disc bulge worse, which they could if we're doing the wrong thing. It to a point, especially when we talk about stenosis, it almost doesn't matter a whole lot if we know the exact medical cause, like what's going on at that segment, because if we can effectively work on the areas around it to take the stress off of that area, and we do that without feeding into your pain, we can be successful, right? Again, no provider is going to change the fact that you have arthritis in your spine, but we can make it move better. We can give it more support when it's doing the things we ask it to do during the day. And we can not only treat the pain, but prevent it from coming back quite effectively, just by getting you moving better, getting things balanced out in that area, and making sure that you're have the tools to allow that to not be a problem for you.
Yeah, one of my favorite sayings for these kinds of back pains with, basically involving osteoarthritis or traumatic arthritis is that, these joints hurt if you move them, but they tend to get worse if you don't move them.
A lot worse. Yeah.
Yeah.
I think, that's a great point. The best example I have of that is in knees. Like people who think they're almost ready for a knee replacement. When they're not moving, I have no problem. But when I go to get up, it's worse. And it's always worse when they've been sitting there for an hour than if they've been sitting there for 20 minutes. And that's because they've been not moving for longer, right? So the longer you don't move and allow these patterns of imbalance to continue to expand, the worse that is going to be. So
yeah, and the spine's the same way. You got to keep it strong. You
exactly.
got to improve the musculature around the spine and flexibility, core strength. Yep. And proper lifting technique. People,
body mechanics.
It's super common that people really have over their whole life have learned how to lift the wrong way.
Yeah. And all of these things, again, have to be individualized to you as a person. And again, the treatment plan really has to be developed around some of the structures that are involved. Again, I don't put a ton of emphasis on the structures that are involved, but if you have a disc, we don't want to do a whole lot of things bending over because that's going to could make that disc herniation worse. If you have stenosis, we don't want to do a whole lot of things that cause you to go backward because that can make things worse, right? So there's things that we need to tease out that are specific to each individual person and some of the structures that are involved in the back pain to make sure we're doing it the right way. And if you go to a provider and you're getting a lot of the same type of treatment each time, and things are staying about the same, then you're probably not getting a very individualistic or individualized program to successfully treat that back pain. So a question here, what is the best exercise? Unfortunately, Diane, it depends because again, if you're in acute back pain, it really depends on what is going on, because there are certain exercises, again, for if you do have some disc herniation going on, that we would want to stay away from a little bit when we're working on certain parts of the body versus other potential causes of back pain. But in general, keeping yourself moving is fantastic, but doing exercise that is going to work on activating and stabilizing your core. And when I say core, I don't mean the six-pack muscles and the obliques. If we strip that away, we have some smaller stabilizing muscles in your abdomen and deep in your low back, as well as your pelvic floor muscles and diaphragm that we need to work on to activate and stabilize in different positions and levels of difficulty, as well as working a lot of muscles through your hips. Your glutes are a big one, getting your glutes working better and getting them stronger. And there's muscles on the sides of our hips that really need to be activating well and strong too. So, Phil,
if I could comment for a second. So,
of course, yeah.
When you talk about favorite exercises for the back, some of my favorite exercises that I have my patients learn how to do to start out with are going to be just Supermans. Now, if you imagine laying on the floor and pretending like you're Superman, arms out, trying to lift one arm up or trying to lift your legs up off the floor. So you're working on really those posterior muscles of your back. They're called your erector spinalis muscles, your back extensor muscles. I tend to have patients in, non-specific mechanical low back pain. I tend to have them start working on those because they don't really put any pressure on the lumbar or on the disc. It's usually a very safe exercise. And then I also have them starting to advance work in their core stabilization, which a lot of times, I like to have them work with PT. Usually the Superman exercise is something you can you can do it at home. It's very safe. You lay on your belly, lift your head up and just kind of progress your way forward. So you can Google that and look up Superman exercises. I really like those. For more advanced people, once we get through, back extensors training, proper lifting techniques. And if the person's capable, to be honest, I will teach them how to do a basic deadlift. If you can lift something up off the floor without pain, you're going to have a lot easier time carrying your groceries up the stairs. I think just a basic functional exercise like those are what I tend to focus on for most people.
I agree. Yeah. And as long as you're not overextending with that Superman. It just needs to be a really small lift. Because again, if they do have a bit of stenosis and they go into a little bit too much extension, that could irritate some nerve stuff they have going on.
Definitely
as well.
let pain be your guide.
Pain's your guide as well. Another one that I was about to throw in there that I like to go to get the glutes working better before we get into a deadlift, because I 100% agree, getting people into that hip hinge squat deadlift motion is one of my go-tos as well. A proper squat and deadlift is starting with a glute bridge, where you're lying on your back with your knees bent. You squeeze your buttock muscles before you lift, and you just gently lift your hips up off the surface you're lying on and coming back down. That can be a great way to sort of retrain our body to say, hey, when my hips are moving in this direction, this is how my glutes are supposed to work. That's another really good one. Again, you can, that's an easy one that you can kind of go on YouTube and take a look at as well. But that's a great one. That's great for the hips, but there definitely has to be a progression. Cause early on, we've got to make sure that those muscles that we need to work in those functional situations, like in a squat or deadlift, are working well. And we need to make sure we progress that right for the individual person. So having some guidance and support there is important for the long-term management for sure. We've had some questions come through here as we've gone, but does anyone else have any specific questions they would like us to answer before we wrap some things up? You can either type them in the chat or unmute yourself and ask, whichever you prefer.
And get out there and enjoy this beautiful day. It's beautiful outside right now.
Yes, it is. Any other questions here?
No mosquitoes yet either.
Right. Yeah, gotta take advantage of that when we have the time. Okay, awesome. So if there are no more questions, we definitely want to get you out there and enjoying the how to measure progress. Okay. That is really based on, in my world, based on where the person started and where you ultimately want to be. And as we work on those things that you need to have addressed for your specific bout of back pain, are you doing more of those things without pain and compensation? Those are the big things. And if you're talking specifically about some of those exercises we talked about, when they're getting easier, like, oh, I feel like I could do this all day, that's a time to maybe progress those and advance those a little bit. Other levels of difficulty, but I really always look at function. What are the primary things that you're having a problem with because of your back pain that you're modifying, that you're not able to do. And then as we progress through through treatment or progress through a program, what are those things improving for you? Are you doing them with less compensation? Are you doing them without pain completely? How close are we to getting to your goals?
Well, let's remember too that there's no end point to the strengthening of your back or your body. Really,
yes.
It's a chronic maintenance thing. It's something that goes on. It's a lifetime. It's a commitment to keeping your body in shape, not just your back, but the rest of your body. But it's something that needs to be done with diligence.
Agree. Yeah, we've got to not only, I always tell all my clients, we're not just working on getting rid of your pain now. We also want to work you into making sure you have the tools to prevent it from coming back. Advice on sitting or standing at the computer. The best thing to do that I give all my clients advice on is you want to be doing a combination of those things. There's no such thing as perfect posture, because if we stayed in even one position that was quote unquote perfect all the time, the minute life required us to move out of that position, we'd have problems, right? Because we get used, our body adapts and accommodates to the positions we're in all the time. So switching it up throughout the day is most important. Sit for 40, 45 minutes, get up, move around, and then you can stand for a little bit as well. But you want to be switching it up throughout the day. That's the best way to make sure we're avoiding problems. Definitely. Great. Fantastic. Any other questions here? You're very welcome. So